Director and friends, good morning all of you. Today I am going to present a case of gallstone disease. As you know, CBD stone. As you know, the gallbladder stone is a very common occurrence, and in every OT in our hospital, we undertake around 2 to 3 gallstone diseases undergoing surgery. So it comes around 20 to 25 cases in a month. But the incidence of CBD stone is around 2 to 2.5% of gallstone disease. But still it's not a uncommon case. And as you know, this gallstone disease may complicate with mucosal empyema, and sometimes a stone may pass, a small stone may pass from the gallbladder through the cystic duct to the CBD, giving rise to jaundice. So the patient may present with biliary colic, a colic type of pain in the epigastrium, with or without jaundice, and cholangitis. Cholangitis means there will be fever, tachycardia, pain, colic pain in the epigastrium, and leukocytosis. So there is features of cholangitis. So the gallstone disease may present with cholangitis, may present with simple pain, colic type of pain in the epigastrium, but it is very excruciating, and associated with vomiting. And sometimes it may precipitate pancreatitis also, when it causes obstruction to the pancreatic duct. And so these are the few of the complications of gallstone disease. With this introduction, I am going to present my case. So my case is a 74-year male, ex-employee from Santragachi, came with, got admitted on April 8 of this year with complaints of colic type of pain in the epigastrium and right hypochondrium for 2 days, with bilious vomiting for 1 day and jaundice for 1 day. There is no associated fever, hematemesis or melena. Case आरंभ करছি আমরা যে গলস্টোন কেস দেখতেছি ওটা নিউরা করছি रिकॉर्ड चल रहा है. There is no associated fever, hematemesis or melena. He was a known case of hypertensive and on amlodipine 5 mg OD. He was not a diabetic. On general examination, patient was conscious, oriented. There was no pallor, but uterus was there. There is no lymphadenopathy or edema. Blood pressure was 140 by 90 millimeter of mercury. Pulse was 88 and regular. There is no temperature, fever. Examination for abdomen shows the abdomen was not distended. It was moving with respiration. There is no venous encurvement, no visible lump or peristalsis. Epigastrium and right hypochondrium were tender. There is no lump palpable in the abdomen. Liver, spleen were not enlarged, and there is no free fluid in the peritoneal cavity. And intestinal sound were normal. Other systems were within normal limits. So we came to a provisional diagnosis of cholelithiasis with choledocholitis with biliary colic and jaundice. So different diagnoses were Meji's syndrome, carcinoma gallbladder, carcinoma head of pancreas. Meji's syndrome is a complication of gallstone disease where a stone, if gets impacted to the cystic duct, it presses the CBD or CSD and giving rise to jaundice. So this case could be a case of Meji's syndrome associated with gallstone disease. Carcinoma gallbladder we give as a difference diagnosis because he was a case of 74 years, elderly person, male, and points against were because only short duration of history, 2 days history, and associated colicky type of pain in the abdomen with vomiting, bilious vomiting. And carcinoma head of pancreas clinically can come to differential diagnosis because there are jaundice. But in that case, the pain is, the jaundice is painless. The colic type of pain in the epigastrium almost excludes carcinoma head of pancreas. And in that case, you clinically you may get a palpable lump, that is palpable gallbladder, because the pancreas, C head of pancreas compresses the CBD and there is back pressure and there is no obstruction to cystic duct, so gallbladder gets distended. So classical picture of carcinoma head of pancreas is painless jaundice, painless progressive jaundice with palpable gallbladder. So when a case of jaundice with palpable gallbladder comes without any history of colic type of pain, first diagnosis is carcinoma head of pancreas clinically. Then we investigate and come to the proper diagnosis.
What about the Miri syndrome?
Miri syndrome is when there is impacted stone in the cystic duct. It may compress the CSD or CBD. So in that case, you may get jaundice. There are different grades. Class 1, 2. Clinically you cannot. Clinically you cannot say.
Clinical carcinoma head of pancreas you can.
Yes. But this will keep defined as a by investigation you confirm or exclude. So we investigated the case. Its total count was little raised 10,500 with neutrophil 79% and coming to LFT bilirubin 5.7 and direct was 3.7, indirect was 2.2. So direct was more. So it is more going towards obstructive jaundice. SGPT was raised, SGPT was also raised, alkaline phosphatase 523, normal was up to normal 130 in units per liter. GVSH and SC was negative. So when you suspected a case of jaundice with gallstone disease, first investigation of choice is ultrasound of the abdomen. So we undertake this ultrasound of abdomen, which showed normal liver, intrahepatic biliary reticulums are not dilated, there is no SOL in the liver. Gallbladder was thick one, edematous, contains multiple small stones, mild pericholecytic fluid collection. CBD is dilated but there is no stone, because sometimes or many times ultrasound cannot give you diagnosis of cholecystolithiasis. But CBD was dilated. Pancreas is normal and there is no ascites. This is the ultrasonogram picture. You see this is the gallbladder, these are stones. Here you can see clearly this is posterior acoustic shadow. This is a stone in the gallbladder and this is the posterior acoustic shadow, which is diagnostic of gallbladder stone. And you see this is the portal vein and this is the CBD. We usually see the diameter of the CBD while comparing with portal vein. Portal vein is taken around 10 millimeter. So we compare the diameter of the CBD with portal vein. If it is more or less equal to, so approximately, but with ultrasonogram machine we can measure the dimension. So it is almost same size or little less than the portal vein. So it is nearing to 10 or 9 millimeter. But there is no stone seen in this CBD. So with provisional diagnosis of, we are going towards cholecystolithiasis. So MRCP is the gold standard to confirm or exclude CBD stone. So on the 18th of April, we undertook MRCP, which shows gallbladder stones, multiple small inclusional bodies. CBD is dilated, contains a small floating stone. And pancreatic duct is not dilated. This is the MRCP picture. This is the gallbladder. This is the CBD which is dilated. And this is left and right hepatic ducts. This is the common bile duct. This is the filling defect, which denotes CBD stone. And this is pancreatic duct. This is normal. which is a genu of pancreatum, and you see bile flow to the duodenum. So MRCP shows CBD stone. This is the test X-ray of the patient, which is almost normal. So with this, our plan was cardiac evaluation and pre-operative anesthetic checkup, followed by ERCP sphincterotomy and CBD stone extraction, then followed by laparoscopic cholecystectomy. This is our treatment plan. So he was taken for ERCP in our department. Patient was kept NPM for about 6 hours. Pre-ERCP IV Tazak was given as a prophylactic measure. Injection Lanta and Voveran suppository 100 mg rectal was given. Because this I will describe later why I am giving. And some people give octreotide, which is for which I have written plus minus. So it prevents development of pancreatitis. So it is not very much conclusive, but some people give. I have not given. So ERC procedure was undertaken under IV propofol infusion. CBD was cannulated and dye injected. A stone was seen as filling defect in the CBD. So sphincterotomy was done. This is ERCP was undertaken on 5th of May. This is the CBD which is dilated. This is left and right hepatic ducts. You see here is the hypodense area. This is the filling defect because of stone in the CBD. And this is the sphincter of the CBD. There is another picture showing this same thing. But ERC procedure was abandoned during the procedure because the patient developed severe bradycardia and hypoxia during the procedure. So CBD stone extraction could not be undertaken in that setting. So it was aborted in the middle of the process. Post-operatively, after 4 hours of ERCP, I advised for a serum amylase which was 620 international unit per ml. This is an indicator or predictor, I can say, for post-ERCP development of pancreatitis. If it is more than 4 times of the highest value of the normal range, that is in this case it was on 130 normal range. If it is more than 3 or 4 times, then it is suggestive that patient may develop pancreatitis. So in our case, this was 620. So we predicted that he may develop mild degree of or moderate whatever pancreatitis. So for the management of this case, the patient I advised him to undergo second sitting of ERCP stone extraction, but patient refused. So patient are posted for open cholecystectomy and CBD extraction on 6th of May. That is post ERCP date 3. But the case was postponed because the patient developed fever, and on examination there are grapes on the left side of the chest. So at that time the ketone count was just upper order of normal, with neutrophil count was high, and as there are grapes on the left side of chest, so we added Targocid in addition to Tazac. And we sent for sputum for further sensitive date, which showed Klebsiella was grown, which is sensitive to Tazac, Magnets, Norflux, Ofloxacillin, Levofloxacillin, and Imipenem and Meropenem. So after conservative treatment, patient was stabilized, fever subsided, chest got cleared, and posted for open cholecystectomy on 15th of May. So patient under general anesthesia, midline incision was given in the upper part of the abdomen, that is APSTM. On pathological findings were gallbladder was thick wall, contracted with omental adhesions. There was no stone in the gallbladder. CBD was dilated. CBD also, I tried to palpate, there was no stone in the CBD. So I aspirated the CBD. We always aspirate before giving the incision to the CBD. and the bile was sent for cultures, sensitivity, which is a routine procedure in our hospital. CBD is opened, there is no stone, dilator passed to duodenum and cholecystoscopy was done to see to confirm the CBD clearance of stones. CBD on the left and right hepatic ducts. So there are clear stones. So saline was given and it was closed with a T-tube of 14 French size. Post-operative TAZAC was continued, but again patient had developed pneumonitis. Had fever, total count was 13,400, this time raised from 8,000 to 13,000 and neutrophil to 91%. So empirically I started amikacin on the morning when I found patient was having fever and chest crepitations are developed. But in the evening when this blood report came, there was creatinine was 2.9, urea was 67 with oliguria. So only one dose of amikacin was given, then I stopped it and I started meropenem, 1 gram thrice daily. And bile culture, which we had sent from the OT, came out with E. coli growth, resistant to all these things, but intermediately sensitive to only imipenem and meropenem. So retrospectively, I thought meropenem, giving meropenem was correct, and patient improved. Total count came down after 3 days to 7,600 and neutrophil 80%. So patient recovered gradually. Abdomen drain was removed on post-operative day 4. Catheter was removed on day 6, and the amount of T-tube drain gradually reduced from 1000 ml to 200 ml on D10. On D10, we usually undertake T-tube cholangiogram again to reconfirm the absence or clearance of the CBD stone, which was normal. This is the T-tube cholangiogram. This is the CBD. This is the left and right hepatic duct. This is the T-tube through which we inject contrast, and there is no stone, or it is clear, and dye is passing to the duodenum normally. This is another close-up view of that T-tube cholangiogram, which is normal.
This is done after how many days?
10 days. Usually 8 to 10 days of operation we undertake this T-tube cholangiogram. So T-tube was removed on usually after this T-tube we clamp this, keep it for 48 hours and see if there is development of pain, fever, cholangitis and increase of total count. Then we suspect probably there is blockage somewhere. But in this case, as it was normal, so T-tube was removed on the D12, stitches removed on same day and discharged on D13. So coming to discussion, so ERC sphincterectomy was done, but because of development of this hypoxia and severe bradycardia, the procedure was abandoned and stones could not be removed by a basket or balloon. And subsequently patient was subjected to operation. But retrospectively now I am thinking, but during operation I didn't get any stone in the CBD. So retrospectively now I am thinking, MRC could have been done, repeat MRC, which would have guided us to go for lap chole instead of open cholecystectomy. But it is another some money matter is there. So repeat MRCP will cost around 7,000-8,000 rupees per the patient. So retrospectively I am thinking, if because that was not successful and because of patient's bad condition I could not proceed to complete extraction of the CBD stone, MRC could have been repeated, so that we could have avoided again open operation, which is definitely more cumbersome for the operator and also for the patient. So in that case, lap chole could have been done. And this I have already told you, the post for our ERCP amylase estimation, serum amylase estimation is a predictor of development of pancreatitis. If it is more than 3 times the upper limit of serum amylase, it is indicative of ERCP induced pancreatitis. And as I told you, bile culture showed E. coli, which was resistant to almost all antibiotics except penems, and that was also intermediate sensitive. This E. coli, from where it came to the bile? Because patient had undergone ERCP, so during ERCP, there is a possibility that we introduce the GI tract organism, mostly E. coli or enterococci, to the CBD, which may give rise to cholangitis or this type of bile culture. And this, if there is obstruction lower down the CBD, this will give rise to cholangitis or septicemia and further complications. So always ensure, while doing ERCP, always ensure that bile flow is intact or maintained. If you suspect something, you put a stent, so that bile flow is not hampered. And this sputum culture from chest, which he had developed during post of ERCP period, it gave rise to the growth of Klebsiella, which are sensitive, I have already discussed. And another thing, in during post-operative period or any time during a treatment, if the patient is diabetic or elderly, or if in a case of jaundice, be careful giving aminoglycosides, because it will precipitate renal failure. So whenever you are giving aminoglycosides, be careful and have a baseline renal parameters. This case it was normal, but still after giving one dose of aminoglycoside, he developed, I described as 2.9 milligram of this creatinine and 67 milligram of urea with oliguria clinically. So in that case, always repeat the renal parameters and change your treatment. So this is, suppose I would not have done this urea creatinine and go on giving aminoglycoside, then it would have ended in renal failure, which would require dialysis or something else. So always be careful while giving aminoglycoside, particularly in a diabetic patient, elderly patient, or patients having jaundice. Coming to some theoretical discussions, other factors which predispose to ERCP induced pancreatitis are young female. This is for our postgraduates. Obesity,